Welcome, Dr. Hardin. It's
you.
a pleasure and an honor to be able to spend this time with you,
Thank you.
At the 21st Annual CFRI Conference. If you would kindly introduce yourself to our online community who can't participate with us this weekend.
Well, I'm Dr. Dana Hardin. I am a pediatric endocrinologist and currently at The Ohio State University and have had my career with studying cystic fibrosis related diabetes and growth in CF.
Dr. Hardin, some patients develop diabetes post-transplant. Is that a form of CFRD?
Yes. Cystic fibrosis related diabetes is a mix between not making enough insulin and not responding normally to insulin, okay? So the reason people don't respond normally to insulin can be due to inflammation. It can be due to different medications. And so post-transplant, we often have patients treated with steroid therapy as well as certain drugs like tacrolimus, which decrease sensitivity to insulin, and then their inherent lack of production of insulin together make that a form of CF-related diabetes.
Thank you. Typically, the onset of CFRD isn't as common in peds as in adults. Is CFRD something that maybe can be staved off or controlled through diet? Or
we would love to figure out completely why everybody who has CF does not make enough insulin, but not everyone who has CF gets CF-related diabetes, although we know that over the course of time, it is more likely to develop. So that is where my research has shown the phenomenon of insulin resistance, and we believe it's from inflammation mediated resistance to insulin. As people age, their pulmonary function gets worse, the production of inflammatory mediators is worsened by worsening infection. Is there a way to stave off diabetes? I sure hope so, and that's what we're working toward, finding drugs that actually change the metabolic problems we know cause CF-related diabetes, understanding how those drugs work and targeting them in younger and younger patients may actually someday be able to help us keep people from having diabetes.
another question we have is, how effective do you feel an insulin pump is for CF-related diabetes?
I love the pump in diabetes for CF. Now keep in mind, some people with CF-related diabetes have what we call transient, or it comes and goes diabetes. And those may not be the best people for a pump because it's a lot of investment if there are times when you don't have diabetes. But for people with CF diabetes where it's permanent, I've done studies, I have multiple clinical patients on pump. They love the therapy because it's a matter of hitting a button to take extra insulin when you eat. As you know, people with CF need to eat. It's so important. And you don't want anything about their diabetes to limit their calorie intake. I love the pump with diabetes.
Thank you.
And with CF diabetes.
Thank you. Are women with CF more prone to gestational diabetes or pregnancy-related diabetes than their healthy peers? And why or why not?
From studies we've done, we actually looked at glucose tolerance testing at every trimester of pregnancy, and we looked at all of the metabolic changes that occur in CF as well as in gestational diabetes to see what happens. So first of all, we had all but one of our 9 study patients develop gestational diabetes in the first trimester of pregnancy. Normally, women don't even get an OGTT till 26 or 28 weeks of pregnancy. From our studies, I have recommended that patients with CF have glucose tolerance testing when they're contemplating pregnancy and from the first trimester on so that they can be treated appropriately. The why is that all of the hormones that are made during pregnancy also cause insulin resistance. So CF women have decreased insulin secretion, and now just because they're pregnant, they make hormones that compete with insulin action. And that's on top of already having CF insulin resistance from other inflammation and other things. So there's a triple whammy for pregnant women with CF to have earlier onset of gestational diabetes.
Thank you. Thank you. And our last question for you, Dr. Hardin, is what do you feel is the biggest challenge in getting mainstream endocrinologists to learn how to treat CF-related diabetes?
I did a survey at our largest pediatric endocrine meeting in the country, and the biggest challenge is our patient load with not CF. We have more and more diabetics every year who are not CF-related diabetes. And the burden of the care in our practice is greater than the number of pediatric endocrinologists or adult endocrinologists being trained. So already there's a time constraint, and to be very frank, I think to do a good job with CF-related diabetes, you do need to have a little different approach, perhaps, than some of the approaches we take with traditional diabetes. I think that CF patients appropriately are very used to being a part of their own management and want a lot of explanation as to why you're doing what you're doing. There's not usually resistance to that from patients. It's why. They want to understand. And so you need to book a little longer visit. I also have found in my practice that my going to the CF clinic, or at least having my clinic run consecutively with the CF clinic so that patients don't make 2 trips for the same disease process, is helpful. But with the burden of other patient care that many endocrinologists have, it becomes more difficult to do that type of scheduling.
Thank you so much.